Namaskar, myself Dr. Vipul Gurjar. I am the head and professor of surgery in SBK's Medical College, Vadodara, as well as private practicing surgeon in Vadodara. Today I am going to discuss about the fistula and why the recurrence and how we can decrease that recurrence of the fistula surgery. So first thing, most of surgeons uh, are afraid about the incontinence during the or after the fistula surgery. That's why they are not doing or they are doing the less surgical intervention or management per operatively, and that's why some part, the residual part, which is remain near to anal canal or near to the sphincter region, and this cryptoglands remains in situ, and that's the cause for the recurrence. But friend, most of these fistula are traversing lower part of the sphincter. So if we are cutting the some part of the sphincter, uh, this may not harm or this may not cause a incontinence. Yes, we have to be careful for incontinence, but 90% of these cases we can deal with the cutting and just resuture back, or even if we are not able to identify the sphincter fiber, this may not cause that much incontinence in reality what we are thinking. Second thing, many surgeons are always trying to probe the internal opening. See, in a like if there is an external opening is found, and these external openings may be a smaller in size, but surgeons trying that I have to probe the external opening and we have to reach up to the internal opening. Sometimes this external opening is so much small and they push the or they force externally to introduce the probe, but these are the smaller track. So this from the external wound itself, this probe is traversing in a wrong direction, and they may after this external opening they may traverse wrong direction up to the visualized internal opening. So in this way also we are missing original track. Third thing, many times the external opening is wide, but internal opening or mid track is so much smaller in size that the probe cannot be negotiated, and that's why they force to come out from the internal opening. But because of the smaller size, it is not possible. So they force and they create a iatrogenic, the another fistula, and that's why the recurrence is possible because that original track remains in situ. So what is the solution is that first is just, if it is possible, then and then you probe the fistula, and it is only possible whenever there is a straight track. Many times or most of times these tracks are not a straight one. On MRI finding you can see this track are curved. In this way you cannot probe easily. So how to do this solution? First, if it is a smaller external opening, then do not push, just to dilate the external opening. And take a 10 cc syringe and break that needle part, and take this syringe filled with the methylene blue with the hydrogen peroxide, and this smaller plastic part of needle you can instill from the external opening. So this may traverse the real track. Yes, you have to some use of force also. This may gives a bluish discoloration of a track. This bluish discoloration will help that the track is where is traveling. Okay. Third thing or fourth thing, the many surgeons are believing in a fistulotomy. But whenever the fistulotomy is performed when there is an immature tract and when there is an infective and the superficial one or the short one. When this curved and long tract, it is very difficult for the fistulotomy. We have to use the coring technique. In this coring technique, what are the advantage? That we are removing the whole fibrous fistula tract from external to up to the internal opening. In this method, we are first instill the methylene blue, start the circular from the external opening, then the color and the thickness of a fistula will guide you where is the tract. Always remains near to the fistula. Whitish color, fibrous, thickened tissue may differentiate from a reddish sphincter and yellow fatty tissue. In this way, you can remove whole fistula tract up to the cryptogland. Once you are reaching up to the cryptogland, you will find a ball-like. If the fistula is mature chronically, you may find a ball-like, a thickened, fibrous tissue, and this is the culprit. So you have to remove all this fibrous tissue, and you have to reach up to the internal opening. Sometimes this internal opening is below line, so you can cut up to the internal opening and the internal sphincter. But sometimes this internal opening is slightly higher up. Then if possible, this you have to trace the tract up to the mucosa or the submucosa. For this, you can use a bipolar for a dissection of the tract. This smaller tip of bipolar will help you not to damage the sphincter, or you will remain near to the fistula tract only. Once you may reach up to the mucosa or submucosa, then you transfix and ligate the tract. So it will not contaminate the stool from the internal opening to your newly created surgical field. Every time it is not possible, I understand. But if you start this procedure, you will definitely be expertise later on. For this coring of the fistula, sometimes you have to cut the sphincter also. And you need a good L-shaped retraction or even a smaller size diverse retractor with the two assistant. Then and then this coring technique will help you on initial days. In this technique, you may reach up to the supralevator space also. And during this coring technique, if you damage or open the fistula, there will be visualization of methylene blue. That means you are in the right way, not the wrong way. Because the methylene blue is guiding that the fistula is covering. So it is a modification of a slough technique, or you can say it is a coring. But during this procedure, you have to remove the central disease part of the fistula. Please do not concentrate every time for the removing of internal opening. You have to concentrate the removal of infected the gland, not the internal opening. Many times, whenever there is a recurrence of the fistula, the surgeons, the patients coming from another surgeon, or the fistula formation after the abscess drainage. And if it is a longer tract or the deep situated tract, then the resurgery of this the fistula with the deep situated cavity, definitely you will find a problem and the chances of recurrence is more. Nowadays, if such case are coming to me, I always convince them to make a mature tract like a pseudocyst. If we are doing a surgery in immature pseudocyst, what happens? Same thing. If you are doing the fistula surgery which are immature, then you may land up in a recurrence case, because the infected and active gland or infected cavity you may not possible to remove. Whenever there is a fibrous tissue, you can differentiate it from the surrounding tissue. I am saying this for the deep situated. Yes, if it is a lower line and it is a straight one, and you can open it like a fistulotomy, then it will sufficient. But if it is a deep situated communicating fistula with the cavity, then not to intervene immediately. Make them much more mature, then and then you can give the good result with the removal of all fistulous tract. Another cause for the recurrence is the post-operative care. The fistula surgery need a good post-operative care, because you are removing the central disease infected part, yes, but because it is normal defecation and during the stool passage there will be a further contamination of wound occurs, so the micro infection always will be there. So the post-operative wound management is equally important for the prevention of recurrence. I say the 30 percentage is recurrence because of the post-operative mismanagement. Then how I am doing? First, whenever the possible, I am trying to keep larger wound. If wound is larger, then the chances of premature closure will be less. Second thing, I if it is a deep situated wound and larger cavity, then I always ask patient or convince patient for a second evaluation under anesthesia after 10 to 15 days. In this second sitting, you may scrap the wound and that will increase the healing rate. As well, there is a if there is a contamination or collection, you may judge during the second sitting. So the second evaluation under anesthesia for complicated deep situated is definitely helpful. Sometimes we are much worried why the second surgery, but it is this small surgery, it is better than the recurrence of the surgery. So it will take only 6 to 8 hours stay if we are doing under general anesthesia and for the just dressing. Third thing, the dressing of a wound, I always try to do the marsupialization. I always nowadays the marsupialization of the fistula wound or the perineal abscess. My recurrence rate is going much more down. Why? This marsupialization make the wound flatten. So the chances of collection under the skin becomes a lesser less. Second thing, these margins are marsupialization in the floor, so the edema of this sensitive skin neurosensitivity decrease and the postoperative pain is also less. As well as this marsupialization will help to clean the cavity. So marsupialization definitely I think picture change in the wound management. Fourth, always do intermittent examination and dressing in a lithotomy position, because we surgeon always doing a dressing in the left lateral position rather than the lithotomy position. Sometimes we are not getting that much exposure, so intermittent if possible every time, but some many times it is not possible in a general surgery or OPD or the dressing room, but do the intermittent lithotomy dressing. Always try to use a forceful dressing, that means air gun or jet water spray for a deep cavity visualization. Nowadays I am using the air gun. That air gun, what I am using for the cleaning of my laparoscopy instrument, these air gun are painless. And when I am using this air gun during this perianal wound, I can visualize very much deep without pain. Without pain, yes, it is a without pain. So once my assistant start the air gun, the wound becomes a separated and I can visualize it very much deeply. So the forceful painless dressing post-operatively is a very good for the cleaning. Many times we are missing the branches of fistula. So there is a internal single or internal opening on examination, on external opening, on visualize examination, but we don't know. Many times these are the branching. The central cavity is remains in the center. There will be a external opening. There will be an internal opening, but this central cavity has a, some branching. If we are not doing the MRI, you may miss. But still, because many surgeons do not have a facility of MRI, or they are not utilized for the MRI as a diagnostic tool because of the cost. But if you inject the methylene blue, you may definitely guide during this surgery of this branch. So installation of methylene blue prior doing any fistula surgery is mandatory, and that will help for the prevention of a recurrence. So at the end, my conclusion: first, do not afraid. Second thing, always trust about for the methylene blue injection installation. Third, coring. Fourth, believe and do the marsupialization. This will and fourth, good assistant with L-shape retractor and the coring technique may be the solution to prevention or lessen the recurrence of fistula. Thank you. Thank you very much.